Good afternoon, ladies and gentlemen. If I could have your attention for one moment. In about 5 minutes, the next session is going to begin in this room. That is going to be Bridging the Trust Gap, Workforce Challenges and Solutions. It is going to be the highlight of the conference. I would invite you to stay here, but if that is not the session that speaks to your heart, my invitation is if you leave the room now so we can begin on time and there's not a lot of moving around. Thank you very much, and I hope you stay. Good afternoon, ladies and gentlemen. If you are still in the room, you have made the wise choice. Good afternoon and welcome. My name is Stephen DeWitt, and I am thrilled to be the moderator of this next session today. We are happy to have this collaboration co-hosted by the CAHSPR Health Human Resource Theme Group and the Canadian Health Workforce Network. We do have some QR codes, so if you want to learn more, please double-click on those. For us here in this room, it's nothing new that the Canadian healthcare system is going through growing pains. But also in this room, we have the brains, the data, and the drive to do something about that. You know, when we think about some of the complex challenges that are facing us in our workforce, sometimes they can be very complex and sometimes overwhelming. But we also have the opportunity to collaborate, to innovate, and to lead to actually meet those challenges. Data is something that we love. Data is something that provides us an opportunity to be able to look and get a real-time, or as close to real-time picture of what's happening right now. It allows us to forecast, and it allows us to predict. But information in and itself is not going to provide all the solutions. And here's the catch. As researchers, as people that rely on data, we can get excited about spreadsheets, about lots of workflow places to look at, and metrics. But the thing, if we want real transformation, it's not going to be about the data. Trust is the game changer. So today in our conversation, we're going to be looking at the importance of trust and what we need to have and to build that trust to make a real impact. That's trust between our workers and our leaders, trust in the data that we collect and we share, and trust in the systems that we build to take care of and allow the people to work in, show up, and be cared for inside of those systems. Trust is the game changer. So when we're looking at trust, it's very important to think about where we stand today and the land that we stand on today. And one of the things that I was in a breakout session earlier, and Jag Bierkor, she said, Stephen, don't mention my name, but she shared this with me. And this is a picture. This was taken 2 days ago in front of our parliament buildings. And inside of building trust, it's important to think about the trust that needs to be rebuilt. These were some chiefs from Alberta that were here to protest because their government wasn't listening to them. So trust for us is still something that's constant, that we have to continue to build with our Indigenous peoples. And now, it's my pleasure to introduce our powerful panelists. We're going to hear 3 stories through 3 different lenses, but one common thread, that trust is a must and trust is a game changer. So please help me welcome Keenan, who's going to magically appear on one of these screens. Yes. Please help me welcome Sophie, and please help me welcome Abby to the stage. Williams. Keenan Williams is the program lead, Innovation and Research with the Indigenous Wellness Corps. Keenan is a member of Sandy Lake First Nations, a fly-in community located in the northwestern Ontario. Keenan holds an MPH from the University of Arizona and a BSc Honours from the University of Toronto. Over a span of more than 17 years, he's worked with First Nations communities across Canada, providing knowledge and expertise in the areas of governance, comprehensive community planning, housing, justice, education, and early childhood development. Keenan is an accomplished Indigenous leader whose passion for improving the quality of care and increasing health equity for Indigenous people shines in his commitment to advancing Indigenous health through several innovative research initiatives. Our next panelist is Sophia Miles. Sophia Miles is an adjunct professor in the School of Kinesiology and Health Sciences at Laurentian University, co-lead of the Integrated Care Models Optimizing Scope Policy theme at the Canadian Health Workforce Network, a member-at-large of the Board of Directors of the Justice Emmett Hall Memorial Foundation, and holds a research appointments at the University of Ottawa, Memorial University of Newfoundland, Athabasca University. She is a health policy, services, systems, and workforce researcher. Her research program focuses on occupational regulation, workforce development, and enhancement, emphasizing health professions to expand and build capacity in a science of professional regulation. And our third panelist today is Abhi Sriharan. Dr. Abhi Sriharan is a leading health systems innovation scholar and the scientific director of the Krambali Center for Health Management and Leadership at the Schulich School of Business, where she leads a cutting-edge research on AI as a driver of healthcare transformation, workforce strategy, and value creation. Supported by SSHRC and SSHRC funding, her work informs global discussions on AI strategy, public and private partnerships, and the future of work in healthcare. She has advised governments, health systems, and industry leaders on integrating AI to optimize care delivery, improve patient outcomes, and strengthen health system resilience. A sought-after speaker and strategic advisor, Dr. Sriharan helps businesses and healthcare leaders anticipate AI's impact, navigate its complexities, and drive innovation and purpose and strategy. I'd like to now pass the microphone to Keenan on screen. Thank you.
Thank you, Stephen. Thank you for the panel. I'm excited to get us started in this first 10 minutes. And I just appreciate the flexibility because I'm calling from Alberta, live in Calgary, and appreciate the flexibility. Trust factored into the ability to attend. So if we could go to the today's topic slide. In the next 10 minutes, I want to do 5 things with you and then keep us moving and toss it on over. I'll tell you a bit about myself and why we should talk about this and why you should listen to me. We've got a notion about trust and some definitions. There's a systematic review that I think a lot of folks in the room might appreciate or benefit from. And then there's the Thunderbird partnership as an example of an overarching framework that we use all the time. But my goal is to fast forward and get right to the heart knowledge questions at the end. So I'll skip through a little bit. On the next slide, I'm Keenan Williams. I'm from Sandy Lake First Nation. I spent most of my life between Northern and Southern Ontario, outside of Toronto, Peterborough, Hiawatha, up in Kenora, Sioux Lookout, made my way out here. So I just love our country, and this is where I'm coming from. But health has been my focus since the very beginning. And right now, I'm working on my PhD at the University of Calgary in the topic of Indigenous data governance. And growing up, my nickname was Pitchfork because I was such a blank disturber. On the next slide, I want to just get a definition of trust up for everyone here. This is not my good work. This is the great work of Brene Brown, and this was from the Atlas of the Heart. But just for level setting, what is trust? And as a nice definition, I connect with this. It's the risk of making something we value vulnerable to someone else's actions. And in the core of our workplace and the choices that we make to do our work, to bring our gifts to what we do, and to have the bravery and curiosity to move forward with certain activities requires a level of foundational trust. So I'm hoping that for the next hour, we can focus on this. On the next slide, I as I was pulling up this definition, knowing that in the Atlas of the Heart, Brene Brown had a really good definition of trust, she had this example of boundaries and the definition or acronym of braving. So I'm going to leave this with the conference participants and tools, but I found this helpful. And I definitely found that there was a few of these boundaries that I know I personally struggle with, but it's nice to have the tools and support and conversation move forward. So a nice additional resource. On to the next slide. Um, this is just a summary of the systematic review from McKellen and team. So 2019, I think there was a couple of other little updates or additional content, but from a broad stroke perspective, if you want to look at Indigenous primary care workforce, this would be one key document I would direct folks to attend to. And there's some key bullets of the content and the changes that we do on the screen here right now. I'm going to let the work speak for itself, and I'll direct this audience to McKellen, but it's nice to be able to say they went from 9,500 articles down to a synthesis of 28. On the next slide, I want to highlight one of the key outcomes and metrics pieces. I really like this table. And again, I'm trying to be action focused in this conversation with the conference participants, my 10-minute window. But there are a lot of conditions that go into, in my particular realm, definitions of Indigenous health and working in, and sometimes non-Indigenous workforces, of which I am one right now. So there's a lot of learning, a lot of conflict, a lot of growth, support, and challenges that comes from this. I want to say that the conditions, strategies, and impacts highlighted in this systematic review is fairly foundational and provides a well-rounded basis for anyone interested in this area to say, I'm just going to pick a strategy on the far right. How do we want to improve supervision, mentoring, and support? There's a list of 8 different bullet points and examples of what's occurred in the literature. So I just want to reaffirm and reassure that we have a lot of content that we can grow upon. We're not starting from nothing. On to the next slide. This is the Thunderbird partnership. They did an amazing national First Nation specific. So this is not Indigenous. This is a distinctions-based approach. And this continuum is focused on mental wellness. So the one example that I use this is our evaluation framework for some life promotion activities that we do in this program and in this province. And honestly, this is a way of thinking that I'm accustomed to and grew up in before I received my Western-based education. So it's a lot easier for me to think in this way. And I want to expose the audience in the room to different frameworks. And very specifically, in the bottom right blue area, sort of in the east by southeast section, there's a workforce development stream. That's the one that would highlight in here. Um, the reason why I'm putting this on screen is to be able to say, we know that all of these are interconnected. However, this model, while not intended to be about workforce development and health human resources, touches upon the importance and criticality of not just considering workforce development, but how that relates to all the other sectors and content that we're wrapped around. On to the next slide. And this is the one I want to sit with the next couple of minutes of our time and what I was most excited about, heart knowledge. There's nothing Indigenous or sacred about this section. All this came from was me sitting with a bunch of academics and researchers going, there's a limitation in this room and I'm complaining because where are we bringing our heart to our work? And I separated between, why did I use that language? I was raised such that I believe we are composed of mind, body, and spirit. And so for the purposes of the work that I do, I try to keep spirit out of it because there's another mechanisms and experiential to do that. But I found the limitation in my Western colleagues was when we only used our mind knowledge, we weren't bringing some of the robustness in. And I understand we don't want to introduce bias to some of our work, but I argue that we can bring our hearts and bring our gifts to our work without introducing that bias, or at the very least, to mitigate any bias in the final analysis and outputs. So how do we do this? We did a randomized control trial with FoodRx, and the whole idea with this study, and a very simple background, is if you're food insecure and measurable and Indigenous, then you get $1.50 a day for every person in your household to buy healthy foods at Loblaws. And there's a couple of grocery stores attached to that, but it was basically through points. The heart knowledge we gained through that work was when the Indigenous subgroup said, subcommittee on the group said, what about the equity for the control group and the RCT who will not receive anything, and they are necessary to benefit from the long-term policy impact of this work, but that individual who's food insecure still doesn't have anything in their stomachs for participating in this. So after the period of data collection has been completed, is there any way to take an equity approach to support the control group with something? And we're able to rejig the budgets and do something to meet that end. So I appreciate that we were able to bring our heart to change some of the RCT approaches. Another example is with Cancer Care Alberta and one First Nation in this province. This started as Cancer Care Alberta saying, we want to strengthen our relationships with how we serve Indigenous people in this province. And we said, do you start with everyone or do you do one thing well? We did one thing well, and that involved a bunch of individuals going to a First Nation for the first time in their career. And that has significantly changed their perspective of relationship building, service delivery, and access in rural areas. The debrief question after a full day engagement session on the topic of cancer services was, is there a moment that lifted or weighed on your heart? And by making space for all members of the team to share some of that content, I really believe that we had a stronger, more robust evaluation and stronger relationships as a result. So I look forward to seeing how that heart knowledge will pay out, and we're already using it in the knowledge translation stream. And the very last question, in 15 seconds or less, I do heart knowledge onboarding and offboarding with staff. So after we hire them, one of the first questions I ask is, I expect as we do innovation, which is the work that our team does, that conflict is a requirement of our work. We will go into conflict because that is what innovation requires. And so before we do that, I do not want to have conflict between our team. So how should I best communicate to you during times of conflict? And how should I best hear and listen to you when you have points to speak? So those my topic of heart knowledge and how we can improve trust with some examples in an Indigenous stream. Thank you, and back to you, Stephen.
Thank you, Keenan. It's wonderful to be with you, even though virtually. And one of the themes that you hit on that I've heard again and again and again in so many different sessions is the importance of that connection, the importance of that relationship, that importance of that trust, bringing our heart. And I love what you said about bringing that into conflict. It's easy to get along when we like the person. It is more challenging to create results when we may have that conflict. So thank you for that. Thank you for your wisdom and your knowledge. And I'd like to now welcome Sophia to the podium.
Thank you, Stephen. So with our time together, I'm going to discuss low levels of healthcare worker trust in organizational leadership to do what is right for patients and healthcare employees in recent research. So after telling you a little bit about myself, I will make connections to moral distress of the healthcare workforce, psychological health and safety, identify a commonly used definition of trust applicable to healthcare settings, and facets of trust that have been explored in the healthcare literature. discuss essential traits of trusted workplace leaders and attributes of trust in leaders and organizations, highlight recent findings, as well as strategies to build trust in organizational leadership. So I am a settler researcher who is very fortunate to work broadly across Canada through academic and research appointments. I approach research through the social constructivist paradigm, and my work focuses on pillars of regulation that both prepare and dictate how professionals get in the system, stay in the system, and navigate the system, structures, processes, and outcomes at the micro, meso, and micro levels, and related factors, considerations, and influences. In healthcare, trust is a critical component on which the entire system rests. It is a central part of leadership and organizational culture that can often go unnoticed until it decreases. Recent developments within healthcare, such as remote leadership, have caused trust to become recognized as a core factor of successful collaborative relationships. Ryan and Lee have said that post-pandemic, the top 3 challenges for healthcare organizational leaders have been described as workforce, workforce, and workforce. A study published by Meadlock and colleagues suggests that to stabilize workforce shortages, it is necessary to rebuild trust in leadership. They assert that leaders must assess how well they are caring for clinicians. Their survey revealed that 45% of frontline clinicians trust their organization's leadership to do what is right for patients, and only 23% trust their leadership to do what is right for workers. There is a high correlation between these 2 types of trust: to do what is right by patients and to do what is right by workers. And this is associated with significantly lower clinician burnout. Organizations have tried to rebuild trust by listening to frontline workers, recognizing their clinical autonomy, elevating their voice to leadership, and building an inclusive culture. The statement that inspired this discussion makes me think of moral distress, which is said to arise when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. In 2013, the Canadian Standards Association, in collaboration with the Mental Health Commission of Canada, launched the National Standard of Canada for Psychological Health and Safety in the Workplace to guide organizations in promoting mental health and preventing psychological harm at work. It consists of 13 psychosocial factors. Based on consultations with healthcare organizations, the MHCC and Healthcare Can developed 2 additional factors especially relevant to healthcare, one of which is protection from moral distress, described as a work environment where staff are able to do their work with a sense of integrity, with support from their profession, employers, and peers. It is important to remember that health workers are people too. Where there is trust in leadership, psychological health, as well as psychological health and safety, have likely been fostered in organizational cultures. Psychological health is a form of well-being that allows individuals to think, feel, and behave in a manner that enables them to perform effectively in their work environments. Psychological health and safety is embedded in the way people interact with one another, as well as the way working conditions and management practices are structured within the workplace. A commonly used definition related to organizational trust in the literature speaks to relationships, power dynamics, and hierarchies in the workplace. Several facets of trust have been explored within the healthcare literature, including trust in healthcare in general, trust between patients and providers, trust between healthcare providers, and trust between healthcare providers and their supervisors. Comparatively, there has not been as much research on what makes healthcare workers trust their organization's leadership. This line of inquiry has been increasingly gaining traction, particularly since the pandemic and in a climate of misinformation. Trust in the workplace is anchored in leadership. Trusted leaders are transparent in their communication. They explain decision-making processes, update workers on relevant issues and metrics, communicate early and consistently, and dedicate time for listening and addressing questions. Trusted leaders exemplify authenticity by aligning words with action. They work to align personal and organizational values, consistently follow through on what is promised for the organization and workers, and regularly self-reflect on how their actions align with worker expectations. Trusted leaders prioritize worker well-being, demonstrating care and compassion, and work to foster environments in which everyone feels heard and respected. They acknowledge contributions to cultivate self-compassion, to extend understanding to others. Trusted leaders navigate the nuanced challenge of recognizing and accommodating individual uniqueness while providing equal opportunities. They tailor employee support based on individual needs and hold everyone, including themselves, accountable. And trusted leadership requires humility to embrace vulnerability, acknowledge and learn from mistakes openly, emphasize collaborative success, encourage input, and give credit where it is due. So some have looked at trust in leaders and organizations separately. It has been found that trust in leadership emphasizes the leader's role, whereas identified components of trust in the organization mostly focus on the functioning of that organization. Trust in leadership was found to include more interactional elements, such as risk and vulnerability, than trust in the organization. Open interactions and collaboration were identified as antecedents of trust in the leader, but this was not the case for trust in the organization. Trust in leadership was found to be at the core of employer-employee collaborative relationships and included positive expectations of benevolence, social interaction, and the leader's competence. Trust in the organization has also included positive expectations of benevolence and social interaction. Linzer and colleagues have found that when healthcare workers trust the organization where they work, they have greater workplace satisfaction and lower stress. Clinician trust is fostered with greater control over work conditions, when quality of care is emphasized, and when there is alignment between the values of clinicians and leaders. Green and colleagues have explored the professional impact on healthcare workers of trusting organizational leadership and leadership actions that build healthcare workers' trust. They found that 42.9% of participants had lower levels of trust. Almost everyone that they spoke to reported that the degree of the trust they had in their organization's leadership has affected them professionally. That impacts of trusting organizational leadership include feeling professional satisfaction and providing a higher quality of work. That trust could be or was earned through effective communication, treating healthcare workers well, and prioritizing patient care. Ultimately, organizations benefit if they earn healthcare workers' trust. For example, employees could spend more time focusing on patient care rather than organizational politics, and they may choose to work rather than to retire. Leadership behaviors most commonly associated with employees' trust include different facets of ethical leadership, caring for employees' well-being, managers' availability, and leaders' competence. Organizational factors associated with trust include employee empowerment, salary, and workload and administrative support. So how can leaders cultivate and sustain trust? They can encourage and seek feedback regularly from those who use the systems and processes in place, know what is and isn't working, and likely have ideas for improvement. They can prioritize authentic interaction and organic connection with staff. And this can occur in many ways, such as sharing meals or having conversations in the hallway. When they can't be on the floor or ward, middle managers are an essential bridge between workers and leadership to know what is happening on the ground. And thinking back to psychological health and safety, empathetic leadership can boost morale, job satisfaction, and inclusivity. And it also fosters comfort, honesty, and transparency to approach leaders when mistakes are made. A lack of trust can lead to a culture of covering up. And mentorship is an investment in workers. Fostering a culture of learning and growth enhances engagement and improves performance. And so I'll just leave you with some final thoughts that central to what we're talking about are people, relationships, processes, and structures. Organizational behavior in healthcare plays a crucial role in shaping success and effectiveness of healthcare institutions. The complex interplay of human interactions, leadership dynamics, and workplace culture has a significant impact on patient outcomes and the quality of care that is delivered. In healthcare settings, it is an applied behavioral science that combines psychological, sociological, and anthropological concepts to understand what motivates productivity and job satisfaction. Healthcare organizations face numerous challenges related to organizational behavior, including hierarchical structures which can contribute to communication lapses, a diverse workforce which increases the need for leaders to effectively manage workers who have been professionally socialized through formal and hidden curricula in training and in practice, resistance to change due to entrenched practices, patient safety concerns, and expectations which require attention to patient safety practices, adaptation, and continuous improvement by organizational leaders. To navigate these challenges, strategies leadership can use to build trust include open communication, encourage consistent collaboration and interprofessional education, cultural competence, shared experiences over time, and demonstrating reliability through timely responses and actions to questions, feedback, or concerns. Thanks very much.
Thank you, Sophia. You know, when I was sitting there and listening, one of the things that kept coming back to me, and I was actually having a conversation with Sarah over lunch, is what does it look like to have relational courage in positions of leadership? How does that show up? Who's responsible? Is it top-down? Is it bottom-up? How do we start that? And so my invitation for you, and where you're sitting today, in your seat, where you're sitting in your career, you are our leader. So how do you build that trust? How do you step into that courageous place to take on some of the things that Sophia shared today in your life, in your work, so you can lead courageously and you can build trust? I'd now like to welcome Abby to the podium.
Thank you, Stephen. Hi, everyone. I know it's afternoon after lunch and after that ice cream. So I will keep this short, and then we'll engage in some discussion. So my name is Abhi Sriharan. And like my colleagues, I wanted to kind of self-locate myself. I am a health services researcher with focus on health workforce and technology innovation. I have been studying trust and motivation for a very long time, since my undergrad days. But I come to this podium as a woman of color who has lived in different countries, worked across multiple health systems, understand technology innovation from a researcher perspective, to talk about what is happening and what's coming to our healthcare in the next years to come. A topic I was hoping that we would see more in this conference, I haven't seen, but I'm going to kind of start to challenge you to think about what's the role of AI that's coming into healthcare and how it's going to change all the dialogues that we are having today. So today I will explore why trust is not just a technical feature, because in AI there's a lot of discussions about how do we make AI responsible, how do we make AI technology perfect. But the trust is also about relationships. It's about the human-heart connection. So we are going to kind of talk about that today in the next 5-10 minutes I'm going to be with you here. The reason patients trust health professionals, we all have been patients in some part of our life, or caregivers. There's a blind trust that patients put towards their care providers, because there's an expectation that the health professionals will act with competence, they will have the right training, they will act with honesty and compassion. That's a basic expectation that's unspoken but expected. Right, whether we are talking about healthcare in Canada or whether we are talking about healthcare in India or Venezuela or anywhere in the world, that's the expectation. But AI is coming into this dialogue. It's saying we could actually help improve a lot of problems that you are seeing in healthcare. In the last 2 years, the conferences I have been to the meeting rooms I have been to, I hear this thing, the common number, 30%, a dialogue being AI could fix 30% of the problem. Every time there's a discussion about health workforce, no, we just need AI, and AI is going to come and fix this solution, right? So that's an interesting debate. And I mean, this is kind of March. Bill Gates actually talked in March of this year, 2 months ago, that within 10 years, AI will replace doctors and teachers. Just sit with that. Within 10 years, AI will replace our doctors and teachers. That's the value proposition our technology leaders are putting to healthcare. There is, this is Dr. Oz. He is part of the current administration. In the US, he talks about healthcare workers could be replaced by AI. Federal healthcare workers could be replaced with AI, right? And we have, I don't know how many of you have, been tracking some of the major reports that's coming out in the Canadian context. Last year, McKinsey, the consulting firm, put out a report saying AI, with the current AI technologies, we could cut 30% of our healthcare spending. It could replace doctors, it could replace certain tasks, certain processes. So that's the world that we are in. There's NVIDIA, which is one of the major technology companies with AI. They are creating AI agents, and their value proposition is instead of hiring a human nurse, you could hire an AI nurse for $9 an hour. In fact, there's multiple pilot projects happening in the US and Canada with these AI agentic nurses right now. So what are we going to do as health policy researchers, health policy makers, system individuals? AI is wonderful. AI could work and do a lot of things that we humans would take months and years to do. It could speed up the processes when it works. But AI also comes with risk. There's a black box of these models, because no one really knows how the models work. There's a lot of push now to develop explainable AI models. So the model has to explain how and why it's predicting the outcomes, but it's not there yet. We are still in the narrow AI space. So you'll have an AI model that's going to do scribing. You have to have another AI model that has to do the clinical decision support for a specific condition. You'll need to have another AI model to do discharge planning. So there's multiple models that you need to develop to do one thing a human could do pretty quickly. There's also bias. So depending on what training data the AI model gets trained, it produces results based on that. There's studies after studies that are showing an AI model that worked really well in one context will not work in a different context if the patient population or the context is different. So that is a big issue, big challenge that we need to grapple with. There's also that value proposition. Like I said, NVIDIA and the major tech firms are saying AI could replace some of the human tasks. So job displacements or replacements are happening without the consequence assessments. I can give you case study after case study where this is happening now. Right? So just to give you a simple example, at a bedside, this is a case from this year from US at Dignity Health. So they had an AI sepsis alert system. So a patient came in, the alert system looked at all the data and said the patient needs to be given IV fluids. And the nurses were out of the workflow loop, so their human was not in the loop. Nurses were there for additional assessments, but they were not part of the decision process. But a nurse who was working in that flow knew that patient, and the patient was a former, he was in that same hospital before and had kidney disease, renal failure. So the patient alerted the doctor. The doctor had to intervene because the nurses had no say in the care process in that, because the AI was making the decisions. So then they have to stop the IV fluid administration. If that nurse was not there, just think about what would have happened to that patient. This is just one story. I hear stories like that from the field all the time. So when the workflows are not designed effectively with the AI and humans are taken out of the loop from a cost perspective, or sometimes when there's not enough human health workers to actually do the work, this can harm the patients at the end of the day as well. Patients come to healthcare, to the healthcare providers, because they want that empathy, they want that compassion. It's no more than saying, like, because right now there's a lot of discussions around AI and healthcare to say, could we just get consent from the patient to say AI is going to be part of your care process and then do the process, right? So yes, you could disclose it. You could tell the patient as part of your care process, AI might be taking notes, AI might be providing clinical decision support. But what patients are looking for is, do I actually matter in this system? My values, like Keenan talked about the different experiences the patients are going to bring, cultural sensitivity. So patients are more likely to trust AI when they know that AI is just a tool, but not a replacement for their health workers. So some of the other things that are happening in the healthcare AI field right now is there's a lot of discussions about the need for governance, but the governance is more around the high level, saying how do we assess these AI tools, how do we implement it, how do we make sure that it's not biased. But at the organizational level, when these AI tools are being implemented, there's lack of governance protocols around how do we ensure that humans are part of the loop. There's not automatization, but augmentation happening. Clinical AI decision-makings are great, but if the physicians or nurses or other health professionals can't override those decisions, then that's going to cause problem, right? And there's also, from a professional regulatory perspective, there's concerns around de-skilling. If we are going to expect clinicians to trust AI to make those decisions, and they are not using their clinical skills, there's a fear that their skills may not become, their skills may become irrelevant. Then what happens? When you have a complex patient and when AI can't actually make sense of that complex patient, who's going to make that sense? There's also concerns about cultural and cognitive issues, especially with the patients. Patients want to be able to talk to humans, not bots. There's a lot of AI studies being currently done using AI chatbots. So in the European context, in multiple countries, when patients get discharged and they go home, AI bots actually follow up, do the follow-up care instead of the human nurses. It reduces cost, it creates consistency, it allows follow-ups, but not all patients are comfortable with talking to chatbots. If any of you have great experience talking to chatbots, whether when you're calling the banks or when you're talking to your telephone companies, think about a patient when they are distressed and they don't know how to actually verbalize what they are feeling to a chatbot. So as health policy makers, as healthcare managers, healthcare decision makers, as we shape and embrace AI, we really need to think about what is the system, what's the organization, what's the leadership we are going to bring to the table to make sure that we are not creating opening up another Pandora's box, but we are actually creating a system that's going to help sustain and address the problems. So Sophie talked about some of the leadership challenges and the opportunities. It's going to get amplified in the next 5 years with this, because there's an opportunity with AI. There's a lot of hype, lots of excitement, but we also know when AI is implemented with a poorly planned strategy, it failed. There's a famous case from MD Anderson. They spent about $64 billion, $64 million in partnership with IBM Watson for cancer care clinical decision support system. 3 years into the partnership got terminated because the health professionals were not ready to trust the AI system. I mean, I could give you cases like this from every country that's happening right now, because it's the system and the strategy was done fairly quickly without thinking through the broader perspectives, the patients and the physicians and the health professionals. So I want to end this talk with two things. One, remember, AI can process symptoms. It's really good in terms of looking through vast amount of EMR data and look for patterns, highlight the issues to the health professionals so they know what has happened for the patient when this EMR information is available. But only clinicians, only humans can actually process suffering. That's what our health professional education is all about, right? You spend 4 years, 3 years learning not only clinical health, but you also learn about the human suffering. That AI can't really do. Yes, there's a lot of research and lots of push towards empathetic AIs to be developed, but there's some unsaid real sufferings that you would watch from human interactions that a machine can't really see. So that is going to be essential as we think about how do we design AI for human-centered healthcare. The last thing I will leave you with, think about this one, is trust in healthcare begins and ends with human connection. Machines are good, AI is going to definitely come into healthcare. It's already here. It's going to disrupt our care processes. It's going to require a lot of new policies and new guidelines and new governance. But the human has to be the center of this dialogue. Thank you.
Thank you, Abby. You've given us a lot to think about. You know, one of the things that Sophia was whispering in my ear, she's like, yeah, what's missing is that therapeutic relationship. What are those interstitial moments that humanity and that connection shows up for us? That's where we can partner with AI and partner with technology and have that work. So the next part of our session today, we're going to have a cross conversation and some reflections from our panelists about what they heard, because we're looking at from 3 different lenses. But before we move into that, I'm going to integrate some of the learning that I've had today, because I challenged you of where you can show up as courageous leaders, where you can build trust. So I'm going to do that right now, standing on this stage. So I'm going to come from my heart, because I learned that from Keenan. I'm going to look about how I build trust inside of leadership, inside of relationships with my AV team. And I'm going to look of how I can partner and trust technology, but also have some of that human element as well. So Conrad, my good man, we have till 3:45 today, not 3:30, and the timer is counting down till 3:30, and I'm having a panic attack up here. So if I could kindly invite you to adjust that so that counts down from 3:45, that would be amazing. Could I get a round of applause for our AV team? They're doing a great job. All right, thank you so much. And now Keenan, if we could have Keenan back on screen with us. There we are. And Keenan, are you comfortable broaching the conversation with your fellow panelists today? What are some things that stuck out from you that were aligned, maybe some things that you want some further clarification on, and even challenging? I think there's something really powerful when we can come together as colleagues and challenge, so we can expand what we see, expand what we're learning, expand the frontier that we're exploring together. So I pass it on to you, sir.
Thank you. I'm trying to be cautious with my first point, because I get the benefit that I was able to take notes this whole time and my other panelists were not able to, so haha. Sophie's presentation very much made me think about the goals, and I feel like we're trying to take a strength-based, what will we do? I'm trying to be cautious in how I say this, but I'm in an organization or setting and province where a bunch of good leaders and trust has been lost. And so I'm personally looking at the best tools and saying, that's the right thing to do. I don't know if I can do that right now. And I'm thinking of the 4 or 5 different tools pieces. So it made me think, during these transition periods, what are the tools that we use to go from distrust to trust? And I know that the earmark of what we can do makes sense, but when there's a high risk tolerance, or when there's uncertainty, or when there's lack of authority that's undermining, how do we grow and build some of those? And kind of, I think it's, to answer just for my own sake, it's the relationships of colleagues, past and present, that keeps one grounded to say the future will be excited. So that's my one experience. And I don't know if there's any hook, but when you're talking about organizational behavior, many of us work in hierarchical organizations. And I remember reading one tool that said, we hire people based on, will you make us look good? Because I got to make my boss look good in front of their boss. So there's a part of hierarchical culture that we might be able to tap into in transitions of distrust to trust. So that was my one thought there. And with Abby, we made this point beforehand, and I'll just say it again for this audience, that I work in Indigenous health. Indigenous health related data is based on how the system was designed, and the system wasn't designed for us and for our benefit. Ergo, fundamentally, any data trained on Indigenous health will have a fundamental flaw, and you'd mentioned that for a bias. And so the opportunity I see with artificial intelligence is, how can we rectify this before we train the machines how to impact this? And for me, and the one key point that I want to leave is relational accountability can exist across systems, between leaders and teams, and involve AI. I think relational accountability has been a common theme across the board. I'll toss it over to the in-person.
Thank you so much. Sophia, do you want to share your thoughts and move on to Abby?
Sure, thank you very much. Just a couple of points. I think one thing that, as I was hearing my colleagues speak, I think a common tie, and I think each of us touched on it in our own way using the different lenses that we use to approach this topic, is that social care happens before healthcare does. There's always that component of social care, just that communication of how are you doing? Like just something as simple as asking somebody how they are doing. And so I think that that's a common tie or thought that pervaded each of our talks. Abby, just thinking about what you were talking about in terms of trust in technology, I think there are a couple of ways like to look at it, and it's patient trust, not only in terms of consent, but just do they trust the technology to give them the information that they are relying on. If individuals cannot necessarily access their providers in a timely manner, they will, of course, go to Google or use any number of the apps that are available right now to look up information. But then there's also the trust of the individual providers or the professions as well. And so it sort of begs the question of if we are increasingly relying on technology, not necessarily to replace, but just to complement healthcare delivery, what constitutes expertise currently and what will constitute expertise in the future? And how can we trust that? Especially when, as you said, we have to really watch this over the next 5 years. And I think this is something that is really a blind spot because the conversation that we're having today will probably be irrelevant in a few months' time. And we don't necessarily know what the risks are, and it's very hard to plan for that.
No, thank you, Keenan, and thank you, Sophia. Like, the trust issue with AI is an interesting one, right? So patients have access to technology now. So if you have been following some of the global news now, UAE is planning to give every citizen in UAE an access to ChatGPT Pro, right? So access to health information, access to going to ChatGPT and say, I have this, and ChatGPT doctor telling you you might have X, Y, and Z is going to be coming to patients near us. So now the health professionals not only have to treat the patient, but also have to help them make sense of what the Gen AI tools are telling them. Sometimes it might identify things correctly. Sometimes it may overhype it. There might be hallucinations happening. So the skill sets we need from our health professionals are going to definitely shift, right? Technology is now going to be a third person in the clinical domain between patient and provider. So how do we do this now three-part relationship as opposed to be the between clinician and the patient relationship is going to be a significant area of work. And unfortunately, our health professional education programs are not there yet. They are training the research of AI, but they are not talking about the human-centered aspects of AI. So next 5 years is going to be definitely key. And to talk about some of the things that Keenan talked about and Sophia talks about, and I think the common element is humility, right? For all of us to say, what do we know, and what are some of the things that we don't know? Even for leaders, we talk about leaders, but every single person in the healthcare continuum is a leader, including your patients. They're all playing a role, so everyone to have that humility to say, I want to listen to you, to understand you, and to build that trust is going to be essential. And I think that's the key theme across the three of us.
Just to quickly add to the point you were making about the education and training has not caught up. I think there's a real opportunity for just health systems and really or the health sector to learn from other sectors or other professions such as law. So while technology is pervading service provision and access, there is no requirement of technological competence. There is in law, though. So I think there's an opportunity for us in our sectors and our fields to learn from others who may be looking at this or implementing these. Certainly to train workers for the jobs that they're going to be doing them and how they're going to be doing them and where they're going to be doing them.
Exactly. I think that's going to be a urgent need. And in fact, I just finished teaching a group of medical students and residents from Queens and UFT last week. And this topic is not part of their curriculum, right? And several of them came to the class and said, I have used ChatGPT to help me with OSCEs, like I will create scenarios. I am self-learning, but they are telling me I can't really use any of these things in my classroom learning. So students are starting to use it, but we are not guiding them in that process. So it's something that as educators, as healthcare leaders, we really need to think about how can we change and adapt our curriculums to the changing environment, changing technology that's happening.
Thank you so much. Shortly, we're going to open the microphones for your questions and some answers from our panelists, so please write them down or start formulating them in your head. Keenan, one thing that you said that stuck with me, you said, how do we, if there is that fundamental lack of trust, there's that rupture in that relationship, how do we rebuild it? And I'm thinking of some of the slides that were shared by Sophia and Abby today and some of those words that were there. I think in my experience and some of the work that I do is number one, we have to identify that breakdown is there. So sometimes in different organizations, people will try and build on top of it, but when that fundamental foundation is broken or unstable, anything that we build on top of that falls down. So I think that's where that relational courage comes in, to actually identify that there is a breakdown first, that there isn't that trust, and only from there we can start building and making that happen in a different way. Does that resonate with you? I wanted to check in.
Yes, it does. And I would add one more comment, that the only way to earn trust is through actions, and actions that become a series of patterns of behaviors that are reliable. And so as I'm growing accustomed to navigating environments of distrust or various levels of trust, then the action and experiential output is I will protect oneself, myself, and our team and our people and I will give the freedom for others to demonstrate they're trustworthy to me, and maybe based on all sorts of different reasons, their priority is elsewhere, but regardless, my investment of energy, time, and focus is not harmed by entering into those conversations.
Thank you. Thank you so much. I now invite our audience members, if you do have a question, please make your way to the microphone. Don't be shy. We're all very friendly up here. We have some people making their way to the microphone, please. Thank you.
Speak for yourself. I'm a floating Wizard of Oz head in another province.
Hi, Keenan. It's Ivy Burchot. Folks in the room know who I am. You know, sort of the gift of knowledge that I received from an elder once is that relationship develops at a speed of trust, right? There isn't a time when you're doing work with Indigenous communities. And, you know, partly, as you highlighted, is that we have to go from distrust. So we're not just starting, you know, tabula rasa with a blank slate. We're starting in the hole. So how do you make that up? I think in linking that with what Abby, you were saying, I want to tease apart, and I think, Keenan, you spoke to this, the development of AI, and do we trust the process of those AI being developed, Why are AI developed in certain areas and not in other areas? And I'll come back to that point in a moment. But teasing apart the trust in the development and the trust in the implementation, right? It's frustrating to see this notion of substitution for practitioners rather than complementarity. And we see that also in interprofessional care, and you know, Sophie has done a lot of work in this area. And you know, I might be totally unimaginative, granted, but I have never seen an AI develop to wipe someone's bum in long-term care, to feed someone in long-term care. And so I'm curious as to what are the spaces that AI develop, and why do we trust AI to develop in those spaces and not in other spaces? So that's just a curiosity. Thanks.
Okay, maybe, Keenan, do you want to go first or do you want me to go first? Okay, I will go first. So that's an interesting observation, Ivy, and thanks for bringing this up. So AI scribes, most of us are now familiar with because primary care and healthcare is coming. There's about 200 plus vendors right now in the market. And I think Canada Health Infoway is putting out this new funding to say 10,000 physicians can access AI scribes. You could purchase an AI scribe based on certain criteria from one of these vendors. Why do we have that many AI scribes in the market versus, like Ivy asked about, the complex healthcare delivery areas? Even just emotional support, not just wiping the bum, but just sitting there and listening and talking. That's hard, right? Writing an AI scribe is a pretty easy technology thing a computer developer can develop. So that's one of the reasons. We are still in that narrow AI world. We talk about AI as a super intelligence right now. We are not there yet. That's like 20 plus years from now, right? So a lot of conversations with AI tech gurus, if they come to this conference, they will convince you that AI is here, it's going to fix everything, you need to invest in it. The failed AI cases are because of that kind of hype. So as healthcare leaders and policymakers, one of the things that you have to make is making that decision to make sense of these AI, especially from the developmental stage, because the patients are not going to think about how this AI was developed. Who developed it? For another example is Epic, which is in most of the healthcare EMR systems. They have a tool called Early Deterioration Index. We have a Toronto-based tool called ChartWatch, right? Epic EDI is being adapted in most healthcare systems because everyone has Epic. Epic EDI makes sense. We trust Epic as an organization, so we would purchase it. But there was a study done by Yale last year where they compared Epic to freely available deterioration index, those ones that didn't even have AI components. They compared 6 different systems. Epic EDI actually performed poorly across all the criteria. So even then, why are we purchasing it? It's because we trust the organization. It's a major vendor for EMR. Right? And the patient is not going to know whether the Epic EMR is actually predicted when I need to go to palliative care or not. So it actually starts and ends with all of us who are part of the policy, governance, leadership discussions.
Great. Thank you, Abby. Keenan, did you want to respond to the question?
I do. I want to take a ever so slight step back and say, artificial intelligence and large language models are the latest tool, and it's the shiniest one, and it's having trillions of dollars invested in it this year globally. Like, I'm not taking that away. But many of these same conversations, I would argue, we had when we started getting electronic medical records and moving from paper copies. Yeah. What will the availability of data be? Who can access it? Is it secure? Will you have what you need about me when you don't have, like, all of these things happen. I think there's a high and very appropriate level of risk to consider. And in terms of the question of what gets developed first, I think it's financial or squeaky wheel driven. After that initial impetus of a new technology, what can all the rest of us do with it and jailbreak, hack, and cause some trouble with? That's what I'm excited about.
Thank you so much. And we have another question from the audience.
Thanks for the presentations. They were excellent. I was struck by the similarity of your definitions of trust. They were almost identical. The idea that trust is defined by bringing something that exposing something that you value and making yourself vulnerable to the actions of others related to this valuable thing to you. And that certainly seems like what we do with our healthcare providers. Our health is valuable to us. We have to expose that to a provider, and we then trust their actions to prescribe the right thing, to diagnose us properly, to help us in some way. And then we saw in Sophie's presentation this conundrum of the moral injury, that you know what is the right thing to do, right? You do know, and yet you may be working in an organization that really, or in circumstances that do not let you act on that right thing that you know to do. I have talked with patients here who have told me they will have gone into their doctor's office and the signs are right there. You can only bring one complaint to me today. That's all I can talk with you about for this appointment. And they surely know, they have to post those signs in their offices, and they know that it's probably not the best care. So my question is this, or from the point of view of a system that has limited resources and constraints on it that really cause moral injury, I think, to healthcare providers and limit what action they can take in a way that could compromise trust. Is it even possible? To what extent is it possible to actually have a truly trusting relationship between the provider and the patient in that context? I mean, I ask this question knowing that surveys do ask patients, who do you trust? Trust your lawyer, trust your teacher, trust your family, trust your physician. And a lot of people say, I trust my care providers, physician, nurse, whoever it is, How is this even possible in this situation of moral injury that can happen and limited constraints, And how do you get around it as a care provider?
Keenan?
I have 2 points, and I'll try to make it quick, but I'm super excited that you said it. I'm going to go back to Ivy's point. You're assuming in the statement of that question that all care interactions are based on trust. And for myself and my family, when we go into in our communities, any interaction with a system, health, justice, education, etc., is an opportunity to lose your kids. Across this country, more than 70% of children in care are Indigenous. So now we're left in this burden of, I've got a broken bone or I've got an owie that needs to be addressed, and I'm entering into this highly concerned space. So that's one experience I'm accustomed to. I would love to get to the trust piece, but moving forward, can I come back? What happens if life happens and my appointment's canceled? Will I still be on this doctor registry, or am I going to a walk-in or something separate? And to your other point about moral dilemmas, I'm going to use an example of some staff that we had that were Indigenous patient navigators. And instead of just moral dilemma, I'm going to take it one step further and say, through the course of the work, we were causing soul wounds as a part of being a navigator when your family, your community members are the ones going up to ICU or experiencing different levels of care that you then have to advocate. And so we were coming up to, and this started when it was coming up to Christmas, and I said, most of us are going on vacation, our navigators are continuing, there's going to be a lot of suffering and difficult times. How can we as leaders support you as staff? And we did not need more staff. We would have benefited from it. We would have loved to have more money to do more things. But what those staff at that time said, my soul is heavy, and just because we could talk safely and trustworthy, we brought in a Blackfoot elder who was able to do some face painting, and that became a monthly activity that we found some operational funding for, because we were not the only Indigenous staff able to experience this. So I know it's a heavy Indigenous stream, but we all recognize this, and find your own way to heal that discord in oneself, be it heart, spirit, mind, or body.
So I think to your question about the moral injury and the challenges that we face in the relationships, there's two sides to the story, right? So there's providers and there's patients. Unfortunately, oftentimes, the patients and the providers are the ones who are facing each other, and there's blame happening from both sides. Providers saying patients are demanding, and patients saying providers are not listening. But there's a third piece about them, the system, that does not get talked about in this. If you talk to patients, they have no idea that we have multiple different primary care models in place, just speaking in Ontario alone. FIG, depending on which kind of model, you might have different type of care. Your average patient won't understand that. So there's a need for patient education about system, and unfortunately our media does not really talk about it. Every time there's a problem in healthcare, it's about the physicians or it's about the nurses. It's about not having the right number of people because it's an administration problem. But we don't talk about the system that's overburdened, the system that has limitations. So the patients have no understanding about that, right? And so the education has to be collaborative with patients and providers, and the system really needs to be transparent about what is happening and why do we have these issues. The media sensational stories are emergency room, wait time is 6 hours, 10 hours, but that 6 hour, 10 hour means there's probably only 2 nurses and only 1 doctor working there, and they're taking care of so many patients that night. So I think there's need for that education about health systems, that every Canadian should understand this is how our health system works.
Just a couple of really quick points. Steve, always really great and insightful question. I'm thinking about expertise, and I'm thinking about the ways in or through which therapeutic relationships are established. So in terms of, why do we trust the provider? My initial thought is just like through their education and training and expertise, that's trusted from the public, but also from the profession, depending on the model of governance or regulation, if it in fact it exists. In terms of how the relationship is established, I'm thinking back to some work that I did with some colleagues, Tracy Adams out at Western, Kate Leslie out at Athabasca, and we found that in the pandemic, it was a barrier to care access was the extent to which, or rather the way in which the relationship was established, particularly in prescribing controlled substances, for example. And barriers to care access were that care could not be delivered virtually if there was not at least one in-person interaction. So just a couple of thoughts about expertise and the ways through which or in which relationships are established.
Great, thank you. Can we have our last question from the audience?
First of all, thank you very much for your wonderful talk. I have 2 questions here. So the first question is to all of you. So we know that AI growth is very rapid, and I'm curious that, how do you see that playing out in working with remote First Nations communities? I attended a presentation yesterday where they talked about some community members still use paper cards for prescriptions. So there are still a lot of barriers that continue to exist. So I'm curious if you can talk about the considerations or conversations that do need to happen when there are a lot of disparities that continue to exist. And then the second question is for Keenan. Again, thinking to how quickly AI is being utilized and the growth there, I'm curious, what do you think about, or can you shed some thoughts on how you see AI fitting into work with Indigenous communities? I also think about the medicine wheel. Does AI have any sort of relationship within that model? Hi.
Thank you, and Keenan, if I could ask you to answer with velocity, good sir, so we can honor the time that we have today.
In the North, I think that it'll pay out poorly, but that's technology access barriers and language. In Indigenous communities, I think the biggest limitation of implementing artificial intelligence will be the experiential aspect fundamental to all Indigenous perspectives and communities in some way, shape, or form. And that piece of experiential data will never be quantifiable in a way for an AI to be able to use, such as they might be able to articulate what a medicine wheel is on paper, but not how to live and breathe it.
Great, thank you. Any other comments from our panelists on this one quickly?
Just a quick point about your first question. AI could, if designed well, could probably help some of the rural health area issues, especially if there's not enough health providers and having access to some of the decision aids. But one of the major challenge is most of our rural hospitals don't even have the computer power to even run these AI models. Like basic infrastructures are lacking in our health system to be even able to think about AI in these systems. So we really need to start with the foundation to be able to build these things.
Excellent, thank you so much. So that brings our session to a formal close. So I first want to acknowledge you for bringing your questions, for bringing your intention to this, and you did choose wisely to stay in here today. I'd ask for you to share your applause with our panelists today, Keenan, Sophia, and Abby. And I would be amiss to not mention Dr. Brenda Gamble, who is the mastermind behind putting all this together. We're getting a round of applause for her. And thank you so much. I hope that you take this into your lives. I hope that you take this into your work. And this is something that allows you to put into action what you learned today. My name is Stephen DeWitt, and our session is now complete. Thank you very much.